This two-part video series addresses an issue of great importance to patients with complex regional pain syndrome. Do some doctors torture patients with complex regional pain syndrome? Part 2. How to deal with a hospital that provides substandard care.
Okay, so today is June 26, 2012, and it is now about 3 or 4 days after her last ketamine infusion, which was a 4-day infusion. Okay? All right. Now, what we're going to do, we just looked at your pain thresholds just a little while ago, and there was a dramatic improvement in your pain threshold. So we know that that this has had a big impact on you. And keep in mind that ketamine is very specific to do one thing, to lower glutamate activity, and by so doing improving your CRPS or RC. Now the next thing we're going to do here is we're going to measure your functional improvements by examination, and then we're going to try to make this into more of an educational type experience. And there's two things we're going to cover during that time. We're going to cover something that's very real that happened to you, and that is when you go into a hospital or healthcare facility and there's substandard care. How do you deal with that? And that happens. And by the way, it happens to some people that are fairly well regarded. I mean, you're a nurse, you're not only a nurse, you have a Bachelor of Science degree, okay? Your husband, Andrew, he is the CEO of a Fortune 500 international corporation. So you're very highly educated, highly regarded people. And when you run into a problem, imagine what it's like for people who don't have all those resources and all that respect to start with. So we're going to cover that. We're going to cover how do you handle, substandard care in a hospital facility. The second thing we're going to talk about is that there are some doctors who actually torture patients that have CRPS. Now, if they're doing it intentionally, of course, that's a crime. But a lot of times, most of the time, it's unintentional, and it has to do with their ignorance. They don't know what they're doing. But they're in fact making patients worse. And the Hippocratic Oath says the first thing is do no harm. Okay, so now we're going to just take a little time here to examine you. You ready for that? Mm-hmm. Okay. All right, so let's do the vertical finger test. Take two vertical fingers in your mouth and tell me if you're having any pain when you do that.
No.
Okay, good. Now I want you to take that right hand and put it behind your head. If you're having any pain when you do that?
No.
Now take your left hand and do the same thing. Any pain when you do that?
No.
Now I want you to take your right hand out in front of you, open and close as fast as you can. Fast, fast, fast. Any pain when you do that?
Mm-mm.
Now do your left side. Okay, very good. Now the next thing we want to do here, if you don't mind, pull your jersey up here a little bit. No, your jersey. There you go. Now this little line we see here is where we started with you in terms of your allodynia being below that line, okay?
Yep.
You couldn't be touched. You were like road burn, right?
Yep.
And these are your little scars, and it doesn't surprise you that your pain is shifted over to your right side because that's where they did the surgery. And we know the most common reason why patients have an exacerbation following treatment, as she had treatment with me 7 months ago, is re-injury, right? Right. And surgery is a re-injury. Okay. So now go ahead and see if you can get past that line without having any allodynia. All right. And do the other side. Do you have any of that at all left? Okay, that's all gone. Okay, very good. Good job. Now the next thing we're going to do here is we're going to test your feet. So I want you to take that right foot off the ground a little bit. Rotate your ankle for me. You couldn't do that before. Wiggle your toes. And hitchhike back to Texas. Get that. Yeah, there you go. You're going to make it. Now keep in mind, this is now 3 to 4 days after your last infusion, okay?
Yeah.
All right. Now do the other. Rotate around and around. Okay. Wiggle your toes. Okay. Hitchhike back to Texas. There you go. Good job. Any pain when you did either one of those feet?
No.
Okay, next thing I want you to do, which we haven't done yet, this will be a first for you, right? Let's see if you can get out of that chair and see if you can stand over there. Mom, I want you to be over there in case she needs any help. We don't want her to... Remember, this walking is a new thing for her.
Yeah, since she's a bit unstable.
Yeah, well, sure. She's been flat on her back in the hospital for about a month. Okay, you ready? Let's see if you can do it 3 steps forward. Atta girl. Good job, Hannah. Good job. Go on back, please. All right, good. And did you have any pain when you did that? And if so, I need to know where.
No.
No pain. Okay. Next thing I want you to do here. Now, Mom, hold her hand. We're doing this not to torture you, but we want to see where we are right now so we can monitor your progress, okay? I want to see if you can take 3 steps forward on your toes. If you can't do it, we understand that. Okay, see what you can do. We haven't tested yet, so it'll be the first. There's 1, 2, and 1 more. That's good, girl. Go on back. Just you can just go on back. Walk back normally. Did you have any pain when you did that?
No.
Okay, very good. Now this takes more balance. Mom, make sure she's got you there if she needs you for balance. Take 3 steps on your heels. There you go. Now go back on your heels. Atta girl. Good job. Did you have any pain when you did that?
No.
Now the reason you're just a little awkward is because you've been flat on your back, for a good month or so in the hospital, okay?
Yeah.
All right. And plus, don't remember, you were paralyzed. I mean, you could virtually had no movement at all when you came in.
Yeah.
Here in Florida to be treated with the ketamine. Okay, have a seat, please. Now we're going to get into the educational part of this interview. We said there were 2 key things we wanted to talk about, and one of them has to do with how to deal with a healthcare facility when the care is substandard. You gave me a call about the problems you were having. I suggested that the first step is to engage the chief of staff of the hospital in the process. That was Dr. Andrew.
Dr. Anderson.
Oh, I'm sorry, Dr. Anderson. And he set up this meeting. And I suggested, secondly, that you record the meeting, audio record the meeting, because there should be a record, okay? And I also recorded on my end what was going on during the meeting. So the meeting was not very productive, to be honest with you. They were all kind of intent on trying to just blow off the situation as being more of an emotional, psychological problem in your situation. And furthermore, what upset me perhaps more than anything else, and correct me if I'm not accurate here, is that during the meeting I asked the neurologist if they were aware that you cannot move your right leg. And they said she couldn't move her leg. And I said, hey, well, have you evaluated her for that? No, we haven't. They didn't evaluate her before for that problem, and they didn't evaluate her for 5 days. They didn't come back to see you for 5 whole days. And as far as I'm concerned, that's negligent. If somebody says they can't move their leg, and the neurologist is probably should be more qualified than any other specialty to examine a problem like that. I mean, for all we know, that could be the beginning of something that has nothing to do with RSD. It could be Guillain-Barré syndrome, for example. Yeah. They didn't bother to come back.
And as per the notes, neurology had actually signed off on the 5th, which was the day before this conference, and I'm very clearly heard on the conference describing the fact that she cannot move the right leg, period, and that they in fact have a sitter beside the bed 24 hours a day who is perfectly able to make note of the fact that that leg is not moving even when she's asleep, not so much as a twitch or at no movement, period.
Right. Okay, but the bottom line is that when your specialty area, you're recognized as being an expert at doing a neurological examination, and you're told someone can't move their leg, and you don't even bother to examine them, that to me that's just unacceptable. Okay. Now, so what do you do when you go to have a staff meeting like this and people just don't want to go in the proper direction to take proper care of you? The next step is to get a lawyer. Turns out we tried to do that, didn't we? And it turns out that this hospital enjoys what we call sovereign immunity. Apparently they have some kind of teaching affiliation. So there's no real incentive for them to feel accountable from a legal standpoint for what's going on. If there's a lawyer involved, believe me, everybody's ears go up. But sovereign immunity limits the amount of liability that the hospital is exposed to if they're negligent in your care. And it takes money to hire a lawyer. And usually these cases are taken on a contingency basis. So we couldn't get a lawyer who was qualified in there to help you through the situation. Notwithstanding that you are a nurse with a Bachelor of Science degree, your husband is the CEO of a major 500 fortune company internationally, you're stuck. So the only other thing you can do in a situation like that is to hold them accountable at some point in time is to file a complaint with the medical board in Texas. And so, so I believe in, myself included, being held accountable for patient care, and they should be held accountable for patient care. All right, so I just thought it was important to get on the record of what people who are less fortunate than you are, if I had to put it to you that way, who don't have the resources, who don't have the experience, who don't have the medical training, and when they're stuck in this situation, what they might be confronted with and what the limitations are. Now, the second thing we want to talk about here from an educational standpoint is this whole business of doctors, some doctors, actually torturing patients. And we discussed that earlier, where if you torture a patient, physically torture a patient, or even mentally torture a patient, it's a crime. There are instances, and I think this is one of those, where you were tortured. Not necessarily intentionally, because the doctors were just ignorant. They didn't know any better. And what happened here is that they began to look at this situation in terms of a differential diagnosis of a conversion reaction versus a psychogenic reaction. Now, there's a huge difference between the two. And what I plan to do with this video is I plan to put up on a slide for a few seconds to see what people are talking about. A conversion reaction is when there's stress, and the stress can be directly related to an organic process that's going on, like CRPS. It's not just in your head, it's physical response to real organic problem. And it can usually results in some type of motor or sensory abnormality. For example, paralysis, as was in your case. Both legs actually eventually became paralyzed, unable to move, as evidenced when you came in. Sensory, where you're just numb, you don't feel anything. It could be, you know, bizarre, actually to the degree of looking just like you're having a seizure or a convulsion. You can have amnesia, where I asked you at one point in time, do you even remember, you know, having these jerking, almost like shaking actions, movement disorder? Do you even remember that? You don't remember that. And I asked you, did you have any control over it? And your answer was no, you don't. So it is something that is not something you intend to happen. It's a normal response, physical response to stress. And when the stress is being generated by a doctor not giving you adequate pain control, as in my opinion what's going on here, it just adds to it. Now, there is evidence to support what I'm saying, not just the anecdotal thing I said earlier about tying, like in prisoners of war, tying piano wires to men's testicles and actually kicking them in the testicles, causing serious injury, where they have a conversion reaction. But there's now very solid evidence that if you stress a patient, particularly in torturing them, you can trigger a conversion reaction. And what I did, I dug up for you, and I want to go over this with you a little bit. This is some data that was done in a refugee camp in Nepal. And these people were in the refugee camp because they were protesting against tyranny, against the fact that they were trying to get a democracy going. And what they did is there was a kind of a homogeneous population, and they looked at those people who were being tortured, I mean severely, heinously tortured, compared to those that were in the refugee camp that weren't being tortured. And they were both men and women. And each group was about 400, so we got a large number of people. And what they did is they asked the question is, and these were psychiatrists evaluating these people. They asked the question if those people who were tortured, is there a higher incidence of conversion disorders in that group compared to the group that was not tortured? And keep in mind, when you are in a refugee camp, that's a stressful situation, so you can expect there to be conversion reactions. The question is it much higher? So if we look at this graph here, what we see, if you look at the percentage of patients, which is on the vertical scale, compared to the horizontal scale where we have amnesia, which means they don't remember anything happening, which is like in your case. And they have movement disorder, which is like in your, the shaking and everything that was going on, and convulsions, and sensory. If you look at the green bars here, that represents the non-tortured patients, and you can see that there's a huge increase in the tortured patients with regards to all these conversion reactions that were taking place. What that says to you is if the doctors are not adequately treating your pain, and more importantly, accusing you of all making it up, which adds to your stress, they are torturing you, and they are creating and they are causing conversion reactions. And as you've learned, when we do something very specific to treat your pain, give you the ketamine, which I asked them to do, which they refused to do in the hospital. When I gave you the ketamine, all of this reversed.
Yeah.
Now, I do have to be honest with you. Some of these patients who were tortured, they do suffer today. They still suffer from post-traumatic stress syndrome.
Yeah.
So this isn't anything to take lightly. This can be a permanently scarring event that takes place in this patient population. Now, when you accuse a patient of making something up, feigning, malingering, that's not a diagnosis. It's an accusation.
Right.
And if you're going to make an accusation, you better have your facts right. For example, simple diagnostic criteria. What you can do is you can just look at the events that are taking place in the patient to see if they are malingering or if they're feigning what's going on. An example would be you would be looking for inconsistencies with regards to audience or time. So an audience would be, let's say, the husband. Every time the wife sees the husband, he's walking around with his hand behind his back, complaining of back pain. Okay? But when she's not around, he's fine. He goes golfing, he does all those things. Now that's inconsistency with regards to the audience, isn't it?
Yep.
Let me give you an example of time inconsistency. Patient comes in, injured their arm, and they have a cast on. They go into the emergency room. Doc, it hurts like heck. Doc says, okay, gives them narcotics. The doc watches them go out, looks out into the parking lot, and there he is selling the narcotics to another individual. That is inconsistent. And if he sees this as a repeated type of behavior, now you have somebody that's malingering. That's the only way you can. And when you don't take the time, and they didn't take the time in this situation, when they used the word, there was no evidence, none whatsoever, that you were malingering. None. Zero.
Yeah.
And that, as far as I'm concerned, is a crime. To accuse somebody of something without any evidence at all.
And what's more, they directly disregarded one of the two that you're just mentioning, because they decided on the 3rd, very early into this awful dilemma that Andrew had, that Hannah had, that she, not only were they accusing her, they started to accuse me and Andrew, and decided that we were reinforcing her symptoms, and suggested that if we stepped out, that her symptoms would improve when she has less stimulation and feedback. It's a big regret that Andrew and I did step out for that one night, because that was the worst night for Hannah, and in fact none of that happened, and yet they still disregarded what happened going forward. Her other leg converted, and she was paralysed then in both legs after they had suggested that Andrew and I were somehow also responsible for causing this.
That's why every doctor, including myself, when you don't understand what's going on, you should be very reluctant to accuse a patient of a malingering or making things up. You should really, because you can do a huge amount of harm. Because you couple that with the patient actually suffering in pain from inadequate treatment, and mount on that is, and the accusation is that she's making it up or he's making it up. And by the way, while I'm on that gender issue, that study that we just mentioned, the conversion reactions were far more frequent in the women population than in the men population. Women are more prone to get conversion reactions than men. So the point is, when doctors are ignorant, they don't understand something, they always are looking around for some kind of excuse besides their own ignorance. Blame the mother, blame the husband, even though you're highly regarded in the community. And then throw on top of all that you are making it all up. That to me is unconscionable. It is disgusting that all that happened. Now, one of the things I want to turn to now, since I did raise the possibility of this being some sequelae that could go on, the post-traumatic syndrome. As you know, there are many psychological techniques that are done to deal with depression, to deal with anxiety, and so forth and so on. For example, biofeedback, progressive muscle relaxation, cognitive therapy. But there is one therapy, we talked about this, there's one therapy that always works. It's universal. Always works when you're trying to improve the psychological part of a problem, and in particular depression and post-traumatic syndrome, and that is called
physical activity.
That's right, physical activity. You got a good memory. Yeah, physical activity. So engaging the patient in physical activity is something that is extremely important. It may hurt, but it isn't going to harm, and it's only going to improve on just not only the physical condition, but the mental condition that you're having to go through. Okay. Not that these other things aren't helpful or useful in some people, but that's something you can always rely on to move you in the right direction. Now I'm going to ask your mom here, since we've talked about this in the past, is there anything that you feel is important that we should add to the story at this point?
No, I think the critical take-home message is that despite mine and Andrew's skill set and resources, which frankly most of the US do not have access to, we ended up trapped in a situation that was unbearably stressful for all of us.
Right.
I am a very consistent and precise historian where Hannah's medical condition is concerned. She has got 3 very difficult to manage organic comorbidities.
Right.
And I was very clear from the get-go that surgery was a big risk, which is why we involved you pre-surgery.
Right.
We didn't know exactly what we were in for, and when we started with this problem, hours after coming off what we hoped was the prophylactic ketamine infusion to prevent this, instead of going to the diagnosis that we knew she had when she started with the rip-roaring pain, they went straight to that first night. The director of the GI service took us to one side, and I said, I'm not sure what's going on yet, and he said, I am. It's a conversion reaction.
Right. And one of the things to always keep in mind, it's a challenge. It is a challenge to make a diagnosis of conversion reaction when you have obvious, as you did in yours, you obviously have a basis for the conversion reaction that's organic in nature, i.e. you just had surgery, you're in pain, and we know surgery can exacerbate RSD. And yes, they gave her ketamine for the surgery, but they didn't give it afterwards as I recommended. They would not do it. They refused to do it. I said, and they could have done it.
Once this had set off,
when they could have treated it. Just like I treated you
unit.
here, they could have done it in the hospital, but they refused to do it.
Mm-hmm.
And the frustrating thing was they had done it for 24 hours. So to say that they weren't capable of doing it, or they were worried about doing it, they'd seen it that it did not do any harm.
Right.
You know, it may not have prevented this happening, but again, we don't know how she was handled in surgery. We don't know how much.
Well, that's a very good point. She's under anesthesia. They don't know what they did to her legs. They could have been doing all sorts of things. Throw her onto the gurney. Who knows? We don't know. And unfortunately, that happens too often. And when patients are put under general anesthesia, things are manipulated, and that can set it off.
And your suggestion would have stabilised Hannah. We know for a fact your suggestion was get her back to the unit and put her on the same dose of ketamine.
Exactly.
Because the movement in Hannah's feet came back within the first hour of infusing her with ketamine. We started at 60, just to be careful on that first day. And within the first hour, before we'd even gone up on the dose, she could move both feet.
Right. And you know, you're right, they could have done it. It was easy for them to do, but they refused to do it. They locked themselves into, and it was this doctor, I forget his name, the GI, chief of GI, who put in the records malignant. And everybody starts getting on that bandwagon. Mm-hmm. And once you get on that bandwagon making these accusations, everybody kind of jumps on it. Who wants to argue with the chief of GI? Okay.
Because somewhere along the line, I don't know whether it was him, but it was passed on to neurology, who had never seen Hannah before, never met our family before, and yet their first observation of Hannah was that, quote, "These are clearly non-epileptic seizures and a history is suggestive of other physical symptoms that were thought to have a psychogenic basis in the past." I'll go on record to say Hannah has never had any symptoms that have a psychogenic basis. She's never been diagnosed as such, so these are subjective judgments by people that are passed on to doctors who haven't even yet examined the patient.
Well, it's not just suggestive, they're fabrication. They're falsehoods. And I strongly urge you to go back to the chief of staff and tell him you demand that there's other errors in the record.
Absolutely.
That we're trying to paint her into the bias, as if it was more of an emotional problem. Bias.
Yeah.
And you need to go back and get those things corrected.
Yeah.
And if they don't, you need to report them.
Yeah, everything will have to be rescinded that is factually incorrect, because it has implications for both insurance and credibility going forward with new physicians.
Absolutely. Absolutely. Well, I want to thank both of you for making this significant contribution to the education of others.
We want to thank you for getting Hannah's legs back.
Okay.